Welcome to GW Integrative Medicine, the podcast about disease prevention and health promotion from the Office of Integrative Medicine and Health at the George Washington University School of Medicine and Health Sciences.
I'm Dr. Misha Kogan, Associate Professor of Medicine here at GW and Chief Medical Officer of GW Center for Integrative Medicine. I'm also a founder and a board member of AIM Health Institute, a DC-based nonprofit delivering integrative services to the medically underserved.
And I'm Janet Rodriguez, the office's Administrative Director. Today, we're discussing poverty, the social detriments of health, and safety net programs in the U.S. with Robert Greenstein, founder and former president of the DC-based think tank Center on Budget and Policy Priorities.
Bob is one of America's leading experts on federal budget, tax policy, and safety net programs. Odds are that you or someone you know, definitely my family, got more services from the government, such as health insurance, financial help, food assistance, because of Bob's life's work. Over the past 40 years, he has worked tirelessly to address poverty in the U.S. and help make healthcare accessible to all.
Bob and CBPP played a major role in expanding our nation's nutritional programs like SNAP, which was called food stamps when I was growing up, and WIC, which is the Special Supplemental Nutrition Program for women, infants, and children. He and CBPP helped expand the earned income tax credit for low and moderate income families. And let's not forget Obamacare. They were very involved in getting Obamacare passed, and they continue to defend it and Social Security from all comers.
Welcome to GW Integrated Medicine, Bob.
Oh, thank you. Misha, I know your work well, and it's an honor to be here with you.
Oh, no. Yeah, it's honor is all ours. You know, I've been personally following your work for a long time, actually. Someone you know very closely is someone I know very closely, and I've been working with her for a very long time. So I've known of your work and your influence in U.S. for a very long time. So it's such a pleasure. It's such an honor. Well, let's start. You know, there was a recently article about you, I think, in one of the largest media outlets. I believe it was Vox, right? And if you haven't read it, I'm sure we can give people a link to that if it was just recently. And we borrowed that statement, the odds are that you or someone you know got more services from the government because of the work. So let's start with that. Bob, let's go back in time. I mean, you've been doing this for probably close to as long as I've been on this planet. How did it all start? And what precipitated you getting on this path of saying, you know, the country needs a lot more support for those less fortunate?
I came to Washington in 1972. Initially, I had some interest in journalism. I had interest in social justice issues. And I was one of two people writing a weekly newsletter on a variety of issues for a nonprofit that no longer exists today. And early in, I asked if I could have the beat that involved food stamps and programs like that. And the more I worked on it, the more I got interested in it. I was very fortunate that soon I could write my articles in just a couple of days a week, and they let me do what I wanted in the other days. And I had two great mentors, one a leading labor lobbyist who was a key lobbyist on social justice issues on Capitol Hill, and the other was really the intellectual driver for all of us on how to think about and expand anti-hunger programs. And so I learned a lot working with them, and within a few years, when Jimmy Carter was president, I got pulled into the agriculture department. And on my first day, given the task of helping to design and pass on Capitol Hill what would be the food stamp changes Carter proposed, which became the biggest expansion in the history of the program, passed in 1977. Then I ran the agency that operates the domestic food programs, school lunch, SNAP, food stamps, WIC, others. I was a political appointee. Reagan won. I was fired. And 3 days after being fired, I started a nonprofit to try to resist the Reagan budget cuts in anti-poverty programs that grew into the Center on Budget and Policy Priorities, which I had the privilege of leading for 40 years. And those 40 years were really the core of what I've done. And I'm very happy that while I'm no longer there as an older guy, I'm at Brookings now part time, but I'm very happy and gratified that my old organization, the Center on Budget and Policy Priorities, is today, I think, one of the most important and effective organizations trying to defend key safety net programs against the onslaught, the unprecedented onslaught they now face.
Mhm. Yeah. Well, you don't know this, but I arrived in the United States as a new immigrant in 1995, and the first thing I got was the food stamps. I was for about 6 months, I think. I was when I got here first, I didn't have any, like my English was not great enough to talk, so I did get a job, I think, after about 5 months. So eventually I started making gradually more money and my food stamps were cut out. But, so I was a recipient. My entire life in US had started because of your work. Otherwise, I would have nothing to live on, literally. And so was the rest of my family when we first arrived from Russia. My
By the way, while
parents.
the SNAP program has expanded substantially over the decades, someone like yourself, newly entering the country today, would not be eligible for SNAP because the 1996 welfare law has a 5-year delay. There's some exceptions, children and others, but generally, people who newly enter the country legally now have to wait 5 years before they can begin to receive the
Wow.
benefits of the program. That was, to me, one of the most unfortunate aspects of the 1996 welfare law. And the current provisions on the Hill make it much worse.
Yeah, it's a topic that I was sort of founding up on how we're going to talk about what's going on now. And I kind of feel like I think we're better off talking about your legacy because otherwise I think we're going to get depressed and we're going to go sideways. And I hope that we at least give not just some hint of hope to people, but also what I really hope to capture here today is your profound legacy that you left. And
the only thing I would say regarding hope,
uh-huh.
I've lived through cycles when we were able to significantly expand for millions of people of limited income these programs, and cycles where they got cut. They got cut in the early Ronald Reagan years. They got cut under the 1996 welfare law. Those are the two biggest, though not the only examples. One bit of hope is that in the past, when there have been cuts in programs like SNAP and Medicaid and others, when the political pendulum has turned, by and large, we have been able to more than compensate for the cuts, to make changes to expand the program so they've ended up more adequate than they were before those cuts were made. Now, that's particularly hard to do, though, with work requirements and cuts aimed at immigrants who were the source of such resentment these days and rhetoric defaming them. So I'm not sure that that'll end up being the case there as well. But there is hope. The worst thing we can do, and people who care about these things can do, is to think it's over if a very bad piece of legislation that rips parts of the safety net passes in the next couple of months. If that happens, then on the next day, we all begin working to lay the groundwork for reversing those cuts or more than compensating for them when the political pendulum turns, as it eventually will. I don't know how many years it'll take, but it'll eventually change.
So you basically single-handedly, with the assistance of your team, did what thousands of lobbyists on the Hill do elsewhere for other industries. What's the secret sauce here? I mean, you really literally achieved the amount of actual influence on the safety networks, on the taxes for the underserved. The magnitude of what you achieved is probably bigger than all of these lobbyists combined were able to. How did you do this? I mean, walk us through a little bit of an actual needy here, because I've recently got involved in some politics on DC level and understand now, like, everything is discoordinated. Everything is a mess. How anybody can navigate anything is beyond my capacity to apprehend. How are we able to do all this?
There's no one item or one secret sauce. And in fact, in most of the things that we did, we worked in alliance with other groups. One of the key relationships I and the Center on Budget were able to build in the 1980s was with key people, and one individual in particular, very high up in the echelons of the U.S. Catholic Conference, the U.S. Catholic Church.
Mm-hmm.
And in a number of these endeavors to defend or expand these programs, some of the religious groups were key. There ended up being something called the Circle of Protection formed, which was all people from various religious denominations, Catholic, Protestant, Jewish, and other. And we basically became the content provider, we, the Center on Budget, and the advisor on strategy to them. And we all work together with them. I mean, the first lesson is if anyone thinks they can do this by themselves or just one organization can pull this off, that's usually not the case.
Alliances and persistence, that's what I heard.
Another key issue, one which I worry at times that some of my colleagues who care deeply about social justice on the left sometimes miss, I fear, is what you don't want to do is simply advance the righteous ideal position for what in the best of all possible worlds changes in the safety net would look like and never move off of that. To me, my guiding principle has always been that people like myself who are, fortunate enough to not be poor, we don't do people who are low income, who we claim to be trying to help, we don't do them any favors if we never produce any results. At the bottom line, you have to deliver results. And so you have to make strategic choices. You have to set priorities. There are times when the only way to get something is part of a larger package that may include one or two other provisions that go in the other direction. You do your damnedest to keep them out or to limit the damage from them if you're getting something that is much more important for more millions of people as part of the same package. I've been subject to my share of strong criticism over the years. How could you have agreed to A and B?
Mm-hmm.
But it's part of the give and take of making big advances overall. So I think that's another key element. You got to really work very closely and on a detailed basis on Capitol Hill and where you can with people in the White House to understand where the boundaries are or where you can push the boundaries to move them and change them. It's really all of the above, and it entails a lot of hard work. So I look back over my years at the Center on Budget. Most of the time I was there, I was working 65 to 80-hour weeks because there were so many places where we thought we could have an impact, and we had to try to do it all. And some places you try and nothing happens, and sometimes you lose, like in the 1996 welfare law, which we very much opposed and counseled against. Funny story is from the outside, we helped organize efforts on the inside of the Clinton cabinet that led to a meeting in which every member of the cabinet but one told Clinton, who was in the meeting, that they thought he should veto the bill. And it'll surprise your listeners to know that my key ally in arranging the effort of the cabinet to try to persuade Clinton to veto the bill was none other than Bob Rubin, who just felt the bill was beyond the pale and some of the cuts aimed at legal immigrants and other low-income people. But those are the kinds of opportunities you have to look for. And I left out one key point. In my view, often these things entail some bipartisan effort. I mean, in the early decades I was here, one of my key champions in expanding and defending food stamps was the late Senator Bob Dole of Kansas, for example.
Mm-hmm.
In 1996, bad as the welfare law was, it could have been much worse. It almost ended the food stamp program and converted it to a block grant. The single individual who was most key in preventing that was Indiana Republican Richard Lugar. There were many issues in which I very much disagreed with Lugar and Dole, but they were key in this defense of food stamps. How do you bring that about? You don't pull your punches, but it is essential that you have accurate and credible analysis and data. If you produce stuff that looks like it's either very one-sided or it's designed to be partisan and just help Democrats in the next election, those people aren't going to work with you. And a key part of the success we had was being able to enlist key Republican staff on the Hill and senators and House members in helping us or in not going along with efforts for much bigger cuts. Now, having said that, things are much more polarized today than they were then. That is much, much harder to do today than it was back then, as we saw just a week or 10 days ago when every so-called moderate Republican in the House of Representatives, every single one, voted for the biggest cuts in the safety net in the history of the country, for what Paul Krugman, whom I remain a big fan of, called in his Substack the worst bill in recent American history.
Yeah. So this is a podcast about health, so we have to turn to Medicaid, since I know you know a lot about it, and your wife and I have been tirelessly in the last few years trying to do something so that the DC Medicaid population will have access to holistic medicine, and that's what I want to talk a little bit about it. Tell us a little bit about some of the key changes that you were involved in DC Medicaid and kind of expanding it over the years.
Well, we didn't have as central a role in Medicaid as in the Earned Income Tax Credit, SNAP, WIC, and some other programs, but we've been somewhat deeply involved in Medicaid all along. One key point I remember is, this is a funny story, at the end of the process on Capitol Hill, on what became the 1996 welfare law, which really decimated what we used to call Aid to Families for Dependent Children. It's now called Temporary Assistance for Needy Families, or TANF. It is the major income cash welfare assistance support for primarily very poor single-parent families with children, and it's a shell of what it used to be. And this bill, it was clear that it was savaging that program, and it was pretty clear at that point that Bill Clinton was going to sign the bill. So in the final week that it was on Capitol Hill, one of my colleagues at the Center on Budget and I went to see a fellow named Ron Haskins. He was the chief Republican staff architect of the 1996 welfare law. I completely disagreed with him on the issues in the law, but he was a decent human being, and he and I had a respectful relationship. And we went to see him, and we said, we're not going to reprise all we've been arguing for you for years of the stuff that you're doing to cash welfare assistance that we think is very harmful. But Ron, have you focused on the fact that the main pathway to eligibility for Medicaid for poor children and parents is that they're on the cash assistance program you're about to obliterate, and millions of these people are going to now lose Medicaid as well. Do you really want them to lose their health insurance?
Mm-hmm.
And he looked at us and he said, why don't you go talk to Nancy Johnson? She was a moderate Republican member of Congress from Connecticut who had some seniority. So we went off and talked to Nancy Johnson, and she got deeply concerned about this. And in the key meeting before final House floor passage, she said, I can't be for this bill unless you make sure that these people don't lose Medicaid. You have to decouple eligibility for Medicaid from eligibility from the cash welfare assistance program that we're shrinking and turning over to the states. And one of the Republican leaders said to her, Congresswoman Johnson, that woman sitting next to you, she's not a member of your staff. She works for the Liberal Center on Budget and Policy Priorities. She is not allowed in this meeting. You have to ask her to leave. And Johnson said, you're right, I'll ask her to leave, but I'm not signing off on this bill until she tells me that you have changed the language in a way that fixes this problem. And that's how Medicaid eligibility got decoupled from eligibility for cash welfare assistance. And over the years, eligibility for Medicaid, due to the great work in past decades of people like Henry Waxman and Howard Berman, and organizations like the Children's Defense Fund, led by Marian Edelman, and Families USA, then led by my old colleague Ron Pollock. Um, Medicaid got expanded over the years to today, and then the CHIP program was enacted on top of that. I think our other key involvement was in helping, along with many others, to prevent the repeal of the Affordable Care Act in 2017. And I thought we had failed. I remember driving to work the next morning, the vote had been very late at night, thinking that it had passed the Senate, turning on NPR and hearing that John McCain had cast the deciding vote and that the repeal had failed by one vote. I almost jumped through the roof of my car. I was so excited. But we did a lot of work there on various things. So, for example, we did a lot of analysis of what the effect would be in Alaska of repealing the Affordable Care Act. Because Lisa Murkowski, you couldn't stop the repeal if you didn't have her. And we had built at the Center on Budget a network of little centers on budget. They were independent 501c, but they were part of our network. And they worked on state budget and poverty policy in their states. And we worked with groups in Alaska. And we were able to get the Alaska media to do big coverage of this using a lot of the data we generated. And I don't know that it by itself made the difference, but it contributed to the effort where Murkowski became a leading opponent too. There were 3 no votes, and McCain was one, Murkowski was one. And Susan Collins, one of the few times she went beyond expressing concern and actually voted consistent with the concerns that she espouses. We'll see what happens on that front in coming weeks.
Yes, we will.
But Medicaid is such an important program. And what's sad about the bill now on the Hill is President Trump and the Republican leaders never use the term repeal the ACA. But in effect, what the bill does is to partially repeal it. It shrinks Medicaid. It makes it harder for various states to maintain the Medicaid expansion. It will allow subsidies for purchasing coverage, private coverage through the Obamacare marketplaces. It'll make that harder to do in various ways. Based on the estimates of the Nonpartisan Congressional Budget Office, whose head is a conservative economist who worked in the Bush administration and at the American Enterprise Institute, despite what the White House or Hill Republicans claim when they try to portray CBO as a Democratic partisan organization, it is anything but. And the CBO estimates indicate that somewhere in the nature, not on the first year, but that over time, somewhere in the nature of 14 million more Americans who today have health coverage through either Medicaid or the private coverage provided through the Affordable Care Act marketplaces, that 14 million more Americans will become uninsured. And in particular, we were talking about immigrants before. It will mean that if states use their own money without a federal dollar involved to provide health insurance to immigrant children and pregnant women and the like who can't get federal coverage because of these restrictions, that if they do that, the federal government will slash the share of regular Medicaid funds for that state that the federal government pays. And the result will likely be that most of the states that do offer that coverage will feel compelled to cancel it in order to avoid a massive budget hole created as a result. So I'm very worried about healthcare for a variety of people who have low incomes as a result of this legislation.
Especially because Americans were getting sicker.
Yeah, that's it. That was my point. I mean, practically they're leading us to even bigger discrepancies in the outcomes, right? Yes. I mean, we're in the capital, or I'm in Maryland.
And then on top of that, you know these issues better than I, but if all these cuts go through, some of these people will not get health care at all or when they need it. Other people won't get it initially, but eventually they'll end up in clinics or emergency rooms where they're handled as uncompensated care. But then that becomes a big burden on the clinics and rural hospitals and others. So I've seen very credible analyses that a number of particularly clinics and rural hospitals in areas where they're the only real major medical provider for miles and miles, that a number of them could fail and go under. And then people could have to go very long distances that they couldn't readily get by. They may not own a car just in order to get to some place where they could access healthcare at all.
And friends, let me just remind you that the scenario that Bob is describing is already here. And what he's talking about basically is the worsening of this situation.
And back on the note that progress really can be made. If you go back, I don't know how many, 25, 30, 40 years, I don't have the exact chart in front of me, but you go back some decades, 1 in every 4 American children was uninsured. And today, 25%, and today only 5% of children are uninsured. This bill passes, we won't go all the way back to 25%, but we'll go back in that direction. But it's just that one statistic is an indicator of how good public policies can really make a very big difference. And you can see declines, for example, in the Black infant mortality rate and things like that over recent decades. Some of them are due to medical advances, but some of them are due to people getting care who didn't used to get care.
And I mean, look at the example. We are in the capital of the United States, and it's one of the largest discrepancies in outcomes. You look at some wards here that are like Bethesda, let's say Potomac, you have longevity upwards of 85, if not even higher. You go to wards 7 and 8, and your life expectancy drops into 60s. If you think about this, that's the difference between some of the top nations and the third world countries in one city in the capital of the United States. I mean, that, like, fundamentally, if you think about this, this is a great example of how screwed up the entire healthcare system is, and they're trying to make it even more screwed up. Like, literally, that's exactly what's happening. We're gonna go into already broken healthcare system that needs complete overhaul, and now it's going to be even worse because financially speaking, there's going to be a whole bunch of people who are going to be completely priced out if they don't have any insurance. There's no way you can buy any services.
And one other unfortunate irony is the rhetoric around DOGE has been, we really don't need so many federal employees. We really have too many rules and regulations. We should strip everything down. Okay, let's look at the bill the House just passed, the so-called One Big Beautiful Bill that we've been talking about here. What does it do on the Medicaid side? And one answer is that it adds all kinds of new procedures, substantially more paperwork than used to be the case. It actually makes the program far less efficient. And in some ways, that's a feature, not a bug, because all this additional added paperwork results in many more people falling through the cracks. And that's where some of the $700 to $800 billion in Medicaid cuts over the next 10 years under the bill, that's where some of them come from. You look in particular at the Medicaid work requirements in the bill. We've experimented with them in 2 states, Arkansas and Georgia, and in both cases, there's virtually no impact found on increasing employment. The big impact that was found was that large numbers of people got thrown off the program and became uninsured, and that most of those who did were people who were already working or who, under the law, should have been exempt from the work requirement because they were raising young children or they were disabled or ill, but where they couldn't navigate all the paperwork or get their phone calls answered. And so they were working, they were doing what the requirements said you're supposed to do, but they couldn't prove it with enough paperwork in sufficient time, and they got thrown off. And the Congressional Budget Office estimates that some millions of people will lose coverage under these work requirements for that reason. And there's one related important point that I keep trying to make these days. There always have been debates on work requirements for programs like these. When I came to Washington in the 70s and then in the 80s and in the early 90s, what a work requirement meant for a program like, say, food stamps was if you were able-bodied, you weren't carrying for younger children weren't employed, that you were expected to look for a job. If you looked for a job, but you couldn't find one, we didn't throw you over the side and say you don't get any food. Under the new work requirements that are in this bill for Medicaid, as well as the intensified work requirements that are in this bill for SNAP, if you don't have a job for at least 20 hours a week, you're not complying. You could spend 50 hours a week looking for a job, but if you can't find one, you're terminated. If you're a low-skilled worker without more than a high school education, you're in the low-wage labor market. The evidence overwhelmingly shows that that's a very volatile labor market, that employers change people's hours all the time. And so the data shows that most of these people who don't work full-time, who are in the low-wage labor market, want to work more hours, but they can't get more hours from their employers, or they can't get them on a regular basis. These are people who are now going to lose their health insurance as a result of the provisions of the bill. They'll be deemed to be not complying with the work requirements. And even though the attempt by the House Speaker, Mike Johnson, and the White House is to say, oh, these are just 25-year-old malingering males sitting at home and doing video games, you actually look at the details of the requirements. The new SNAP work requirements in this bill apply to people up to their 65th birthday. If you are a 64-year-old widow who can't find employment and you live in an area where the unemployment rate is 9%, recession level, under this bill, they take away all your food assistance after 3 months.
We got to switch to something positive here, because I feel I'm getting the more I listen to you, the more depressed I'm getting.
The thought always has been you look at the full extent of the damage and you use it to fortify your determination to fight back.
I love that.
Absolutely.
I think that's such a
Me
great
too. I love
statement.
that.
I love that. That'll wake me up tomorrow. And so we're trying to, what we're trying to do. We're trying to say, look, there's DC is a fourth place in U.S. where people die from opioid crisis, and it's up to primarily DC Medicaid to try to help to fix the problem. So we've been aggressively saying, look, you're not going to fix the opioid problem because you're prescribing people a bunch of opiates for pain. You have to find alternative treatments for that. So we've been advocating aggressively kind of a holistic or integrative approaches for chronic pain, and hopefully moving somewhere. But it's going back to 70s. I mean, the Medicare Medicaid has never been established to manage chronic problems. It's been established as an acute care model, right? Back in the day, the concept of chronic care management didn't even exist. I mean, we're talking pre kind of all of the current infrastructure. So it's a provocative question. Can, if at all, programs like Medicare and Medicaid actually turn into effective chronic care management programs, or should we really redesign it all from scratch? And I don't think I want to go into politics of this, but I'm questioning whether the current infrastructure fixable whatsoever, and maybe indeed we have to, in some phases, design a completely new structure and then say, look, we're going to have an acute model for hospital admissions, for emergencies. And then we also have some kind of a brand new infrastructure for chronic care model. Have you ever thought of what it will take to sort of have a truly integrative process for health, not just for disease management, which we clearly failing to do?
Yes, but I have a different perspective on this. I mean,
Great.
In the ideal world, if wishes were horses, sure, I'd love to see a single payer national healthcare system. But we're not going to
that's where I was going. I was hoping.
But we're not going to get there.
I know.
It's really.
But I can dream. Look, I did I did residency in social medicine, right, in New York. And so we've talked about single payer system for hours on end during some of our lectures. And I was like, at some point I got disillusioned. So I know you're absolutely right. I know it's not a future. But what if we take the concept, try to distill some benefits out of this concept, and then stick it into the current system?
So a couple of thoughts. I'm not sure I'm going to get the exact number here right, but something like 150 million Americans have private health insurance. Some people don't like it, but millions of people do, and people are understandably cautious and protective. So, like if a presidential candidate ran and said, I'm going to do away with private health insurance and replace it with single payer, the odds are that that candidate would have much greater difficulty winning the election. And of course, you'd have overwhelming, powerful opposition from many aspects of the healthcare world. So, to me, the question then is, and as a larger thought, for me, if I take all the work that I've done over the last 50 plus years in trying to expand the safety net, all of it has been incremental change. Any individual incremental change may not look that big, but when you do increment upon increment upon increment, you keep coming back and coming back and coming back. Over time, it can build to larger things. So I view the passage of the Affordable Care Act, Obamacare, in 2010 as really a pretty extraordinary accomplishment. It was not single payer, but it took the existing system and in various ways, it expanded Medicaid that historically left out people who weren't elderly or disabled and had children, and it made it more of a universal coverage program among people with low and modest incomes. That and other legislation have strengthened the integration of Medicaid and Medicare so that for lower income people who have difficulty with Medicare premiums, now Medicaid covers much or all of the premiums if you sign up appropriately. The new bill on the Hill makes it harder to sign up, but that's another story. The marketplaces, yes, they were private insurance. If they hadn't have been, Obamacare wouldn't have passed. And if it had passed, it would in fact have been repealed. But the insurance provided through the marketplaces had all kinds of new rules, pre-existing conditions and other kinds of things. So to me, the question is, how do you continue to build on Obamacare? If your ultimate vision is you want to get as close to a national health insurance structure as possible, but as I said half an hour ago, you don't make any progress if you don't pass anything and you fail. What's the maximum amount that you can actually pass? And then come back the next year or 2 years later and pass the next increment that's the biggest you can pass that. So that's, to me, that's the task. When the time comes and the political pendulum turns, beyond undoing the unspeakable changes in the bill now up on Capitol Hill, beyond that, what are the next significant steps that build upon the current structure, but gradually move it more in the national health insurance direction? I think when Medicaid was formed, enacted in the 60s, people would have been astounded to see how much more expansive it is and the creation of the Obamacare marketplaces on top here 60 years later. And when people look 50 or 60 years from now, my hope is they look back at the way the system worked today in 2025 and say, boy, that's so much more limited than where we are today. That's my hope and vision of how to pursue this.
Well, I hope that in 50 years from now, when we do have whatever the healthcare insurance system will be, that it actually will pay for maintenance of health instead of treating disease only. I think that's the biggest amiss that philosophically happened back in the days, that we presume that if we simply treat medical illnesses, that we will be able to have a healthy nation. And that's, I think, why we're in a mapping the floor when we should be turning off the sink.
I think there are two related but distinct issues here. I'm talking about people having ready access to affordable health care. And you're making the very important point that, critical as that is, there are issues in what passes for healthcare itself.
Exactly.
And that improvements are needed not only in the coverage for care, but in the nature of the care that is delivered.
Yeah. And that's a monumental task, I think, of current generation and future generation of physicians to say, look, healthcare system must be responsible for health, not for illness only. And whether or not the current administration has this MAHA idea and whether that's going to turn out anything will yet to be seen. But I actually like that there is that conversation out there, because it's the first time on a top level everybody's starting to say, wait a second, where is the health in all this? Because we only talk about illness. We only talk about coverage for diseases and acute care, but we need some system for health. And, I don't know. Am I hopeful? I'm hopeful in a pendulum effect. I hope that eventually things will swing to the point where some of the seeds that are planted now in terms of, okay, let's make the America healthy again, will actually make America healthy again instead of just, whatever conversation is, because it could just end up being conversation.
The only comment I'd make on that, I don't think you would disagree with, is to get the kinds of changes we need. If either the only people pushing for them are people who consider themselves socialists, or if there's a sense that others aren't welcome, then none of them are going to happen. I'm a big tent guy. We need the biggest tent we can
I love
get.
that. I think
I really am very unhappy about the current battle within the Democratic Party between moderates and so-called moderates and so-called progressives.
Yeah, I agree.
If we don't all unite, things are going to continue to get worse in the way they have been in recent January 20th. And all of our hopes that we've talked about for the last 45 or 50 minutes are not going to come about. We need the biggest possible tent.
I love your principle of the changes that we can do. There's always give and take, and we have to learn to do that effectively instead of just having this completely divided process. So I don't know. I'm a paradoxically, despite the fact that I survived the worst nightmare of childhood being in the former Soviet Union, I'm an optimist at heart. I mean, I think come up with the solutions in our lifetimes that will lead the country into way better healthcare. Because I mean, it's kind of pathetic that we are, I don't know, I think we dropped even further. We used to be number 35 in the world. I think we're now at lost in at 39 in terms of average health outcomes. And yet we're spending more money per capita on healthcare
than anybody else.
No, not only that, than a bunch of countries combined.
Yeah.
So I like to think of myself as a realist, and it often means being a pessimist in the short run, but an optimist in the longer run. I once had somebody say to me, "Boy, you're such a pessimist." I said, "No, I'm really a long-term optimist. If I weren't, how could I have continued to do this all of these years? If you just completely succumb to pessimism, it disempowers you and you give up. The last thing we can do is give up."
Well, that is all the time we have for today. Bob, thanks so much for joining. It was such a pleasure of having you here today with us.
This is the GW Integrative Medicine Podcast from the GW Office of Integrative Medicine and Health.
I'm Dr. Misha Kogan.
I'm Janet Rodriguez. Thanks for listening.